morning. They always put me just before the lunch to make you hungry. My name is Emir مراد. I'm a plastic and craniofacial consultant from Riyadh, Saudi Arabia. I'm also an assistant professor at Al-Faisal University. Today I'll be talking about Vicross technology with fillers of the face. What we'll do, I will talk about beautification to start with, then introduce you to my technique, and then best practices, and then we'll do a live demo on 2 models. So again, the outline, I'll talk about measures of beauty and aging. Dr. Ala Arif will talk more about this later this evening. I'll discuss anatomy, which is very important to anyone who treats patients, especially with the face and especially in aesthetic patients. I'll take you through the consultation. Again, it's an elaborate consultation that we do, and there are many measures that you need to take care of when you're consulting your patients. We'll talk about injection details and the different techniques of injections, and then I'll discuss my technique. I'll touch base on the MD codes, and then talk about complications. Unfortunately, we need to talk about complications, and then we'll go to the live demonstration. So there are generally accepted principles across gender, ethnicity, and cultures. I'm sure most of you are familiar with the golden ratio, and it's a magical number of 1.618. You might apply it to your practice or not, depending on your understanding of this concept. Also, symmetry, balance, and harmony are extremely important. I'll show you this video. This is done by someone called the photograph surgeons, as if we don't have a lot of competing people for the title surgeon. But this patient, she looks nice, but there are some deformities in her face when you look at her. She has more heaviness in the lower face. So this artist applies the golden ratio to every subunit of the face. In addition to applying the golden ratio, he applies symmetry with both sides, and then some Photoshop clarifying the skin. And you'll see the results at the end. So here you can see the every time you see that overlapping diagram, and that has all the golden ratios embedded in it, and he applies it to the face. And now you can see the result, the end result, showing much more structured face and much more beautiful, I guess. In a minute you'll see the comparison. So that's her after, and that's her before. Great difference just applying the golden ratio. Some of this can be applied with aesthetics and using fillers and botulinum toxin, and some other with surgery, that we can help with surgeries, with implants, and other modalities. So in addition to these 2 points, you have key elements of youth and health. I'm sure a lot of you have seen in their practice patients with permanent fillers or overdone with injections. To me, they look unhealthy. And it's an interesting study that we can do to the layman and see if they look at these patients as beauty or unhealthy. Aesthetic trends and patients' personal preference. So I live and work in Riyadh, Saudi Arabia. The trend is more of an international trend because of the internet and the social media. So all the faces I do, 90% are structured faces with stronger malar eminences and a stronger mandible and a contoured groove in between, in the mid-cheek area. I get patients from around Saudi Arabia. So I had a patient from the northern region, and I did my structured face, not paying attention to that aesthetic trend or patient's personal and surrounding environment. The patient was not satisfied post-operatively, and with further discussion with the patient, I found out that she wanted a fuller face. So you need to understand patient's need and desire and her area and what is the trend in her area. Dr. Arthur Swift, in his article Beautification, talked about the Magnificent Seven. And these are facial features that influence our perception of facial beauty. The first and utmost important is the facial shape. And I've just discussed it in terms of contoured shape or a full face or other shapes as well. The forehead height is extremely important. That can be controlled with either toxins or fillers. Eyebrow shape, Dr. Jamal talked about the eyebrow shape using surgery. And again, we can use toxins to control that. The eye size and inter-eye distance, and then the nose shape. The inter-eye distance and nose shape go side by side. The lips and what we can do to the lips, in my technique, I'll discuss further with the lips. Skin clarity, color, texture. I'm sure the dermatologists in the house are more familiar with that part. So what are the factors that contribute to time and degree of facial aging? There are intrinsic factors and extrinsic factors. The intrinsic factors include genetics, time, evolution, and how expressive is that patient. The more expressive they are, the more aged they would look. Atrophy of the dermis and subcutaneous tissue, bone resorption and changes, and then body weight. I included body weight in the intrinsic factor because I have no control over it. So it's intrinsic, I give it to that. There are extrinsic factors that we have control over some of them. Gravity, as Dr. Jamal mentioned, if you're on the moon, you would not have that. Sun exposure and smoking. The highlighted ones are interesting. There was a study made that compared identical twins that live in different areas and have different habits. So in terms of sun exposure, they compared a twin sister living in Canada, where it's cold and you're in-house all the time, with her identical twin down in Miami, in Florida. And the sister in Miami, who's exposed to the sun and sun tanning all day, has aged dramatically more. Another factor is the smoking. Again, compared identical twins, and the smoking affected that also in severe shape. Body weight is an interesting factor. There was a limiting age factor. So at age of 40, if you're below age of 40 and have a high BMI, you look older. If you're above age of 40 and have high BMI, you look younger. So that was an interesting study done a while ago. I'll take you through the timeline of aging. Initially, at the age of 30 to 40, you'll develop some redundancy in the upper eyelids. You'd have crow's feet developing, and the nasolabial fold deepens. Further down the road, you'll have the lower eyelid starts to show, glabellar and forehead wrinkles, the outer brow starts to droop, the cheek fat descends, fat atrophies in the cheek and temple, and then you get extra redundant skin in the neck. Further with aging, you get eyebrows droopiness, nasal tip droopiness, lip thinning, perioral wrinkles, marionette lines, jowls, and platysmal banding. Does anyone know why I have this creepy photo up next to my slides? Marionette. So this is called a marionette, and the marionette lines comes from the mouth that moves with these dolls, and you get these lines. So they call them marionette lines. Jowls, I have no clue why they call them jowls. And then, last but not least, you get further facial skin thinning and continued atrophy of fat in cheeks and temples. So we have in our armamentarium modalities to treat a lot of these factors. You're not removing them completely, but you're hastening them and postponing them for a later age, where surgeons would come in and hopefully reverse that factor. This is another video that will take you through the aging process of this patient. This is a photo in the middle of her age, but I'll start with her as a kid and we grow together. Have a look. I'd like you to focus first on the periorbital area. So you start have lidding of the upper eyelid, and then hollowing of the lower eyelid. Further down the road, she has the nasolabial fold deepening, and then the perioral aging. Again, further down the road, the cheeks starts to descend. She develops the jowling and develops the downturning of the angles of the mouth. with further thinning of the skin and further periorbital aging. I believe in individualized treatment, and here is where I differ with the MD codes and Dr. DeMaio. In Dr. DeMaio's and the MD codes, you try to unify and standardize the treatment. I believe in individualized treatment. I think standardizing the treatment is good for beginners and intermediates, but advanced injectors should individualize treatment. Aging and aesthetics are unique to each patient. We should individualize treatment to improve outcome. That's what we all aim for at the end of the day. So how do you individualize treatment? By product selection, dosing, and placement. Improved outcome increases patient satisfaction, and we all go home happy. Now I'll talk about important clinical anatomy of the face. Again, this is crucial to understand and know before you start injecting on your patients. If you're not familiar with or you need more studies of that, I'd advise you to go to the lab and try on cadavers before you try on humans. So first and utmost important is the vessels. Vessels, there are specific areas where you can inadvertently inject intravascularly. The first area is the facial artery as it crosses the mandibular angle in the mid-mandible. Here, do not go deep on the bone, otherwise you will inject that vessel. If you inject that vessel, that will affect the whole facial artery with the angular artery and might cause problems on the nose or the cheek. The second point is the angular artery, just lateral to the ala. In the past, people used to inject all around the nasolabial fold. In recent years, with more anatomical studies, we've noticed that you need to go medial to the nasolabial fold to be safe and more superficial. Even with all precautions that you take, you might inadvertently inject the vessel. I had a patient a couple of months back where after injecting, 2 hours after injecting, she traveled unfortunately to another city where she came from, and she called me at 3 a.m. complaining of pain and some blanching on the nose. I didn't touch the nose, right? I just injected the nasolabial fold in my usual technique, medial to the nasolabial fold and all that. I referred her to a local clinic there, and then I asked her to travel back to Riyadh the next day. Next day I injected her with hyaluronidase. It's never too late to inject hyaluronidase and try to melt the product around the vessel. It could be compressive or intravascular injection. So dilute it as much as possible. I use corticosteroids and antibiotics just to be on the safe side. She's healed nicely, but it took 2 to 3 weeks during my vacation time, where I have to check her photos on a daily basis on my phone and calm her down. And in a few weeks, she returned back to normal with minimal scarring on the nose. The third area, I think it's the most dangerous, is the glabellar and medial orbital area, where vessels connect with the retinal artery and can cause blindness. So again, if you're injecting in this area, you have to aspirate, you have to be very superficial, and be careful and keep your hyaluronidase close. In terms of nerves, this is more important, of course, when you're talking about botulinum toxin. But again, if you inject close to these areas, the supraorbital and supratrochlear nerve, the infraorbital nerve, and the mental nerve, there's always an accompanying large vessel next to these nerves. So inadvertently injecting these vessels might cause problems. If you inject deep and close to that nerve, compression can affect the nerve, and you'll have numbness in the area. If that happens, I've never seen it or heard about it, but if it happens, you just need to dilute your product with hyaluronidase. So now I'll go to the consultation. There are many standards that you have to have in your clinic in terms of the consultation. It is extremely important to give these patients enough time to understand, especially if it's the first time, what you're doing, how you're doing it, what are the possible what are the outcomes and possible complications. So it's like a checklist, and for the advanced injectors, this goes beyond without thinking about it. You just go through your checklist in your mind and with the patient. History, it's important to focus on infections, previous infections with fillers, or a history of herpes simplex virus that you might exaggerate after the treatment. Any allergies, pregnancy and breastfeeding, I do not inject toxins or fillers during that period. I ask them to come after they're done. So any bleeding issues or tendencies, if the patient is on blood thinners and aspirin, it's not a contraindication to inject patients who are on aspirin or blood thinners. You just need to be careful while you're injecting them, not to be close to a vessel to not cause any hematoma or bruising in that area. And tell the patient that their possibility of having that is higher than other patients. And also take your time applying pressure after each injection. I asked them about previous aesthetic treatments and where they had it done before. I asked them about their likes, what they like about it and what they dislike about it, and their reaction, their family reaction, and their friends' reaction. If it's a positive outcome, I try to imitate and repeat that result that she had. If it's a negative outcome, I'll be more careful and maybe manipulate the treatment a little bit. I always ask the patient about their main concern. So point out 1 to 3 areas that you're concerned with. And we focus on those. If I see any other areas that might benefit from my treatment, I would point that out to the patient, but I would not insist on it. I discuss how the fillers work and also toxins if I'm doing toxins, and how long they last, the possible adverse events, the treatment plan, and cost. Cost is extremely important, especially nowadays. We have global economy is shrinking all around the world. So I think a discussion about cost is important. If you want to do it yourself or you want your secretary to do it, it's fine. But try to get an estimate of the patient's budget. And then tell her I'd either focus on one area and make it look a lot better, or I would spread the product more around the face and you'll have a lesser result, and see what she chooses. Make sure to include that maybe in your consent so she's not upset afterwards. Patient assessment and photography. Again, this is crucial. Photography, we take photos for all our patients, medical photos, AP, lateral and oblique. And it's important to do that specifically to the very, very meticulous patient, or you know who I'm talking about. So these patients, you need to document that with a photo, so that post-operatively, if they come, you can point out their deformity in the photo. Consent. We all should have consents in our clinics for these patients. The consent should include, it's a general consent, so for toxins and fillers or platelet-rich plasma and any treatment, superficial treatment that you're doing. In it, you'll have to include the possible complications, the possible outcome that the patient might see, and any further treatment that the patient might need. I might point out special points within the consent and ask the patient to initial next to it, so that so we are on agreement, and when the patient knows about the possible complications, when it happens, they are less dramatic and you have less pain dealing with them. Facial sheet for documenting your procedure. It's much easier for me to document it on a face. I'll show you my sheet in a minute. And then we talk about after treatment care and follow-up. So in general, I do not ask them to massage the area, whether toxins or fillers, and no pressure on the toxin area for 2 to 3 hours post-treatment. After that, they can do whatever they want. In the MD codes, they include the emotional attributes. This is important to have a pre-injection with the patient and discuss these emotional attributes. If you pinpoint what the patient desires and what she feels she looks like, you might be able to address that emotional need as well. So there are negative emotional attributes such as looking less tired, less sad, less saggy, and less angry. And there are positive emotional attributes where patients would like to look more attractive, younger, slimmer, and more feminine or more masculine, depending on the gender of the patient. So this is an interesting concept. It's still new, a few years back. And I think it's important to include that in your discussion with the patient. What do they feel? It's similar to our photography when we do 3D animation for the nose. When we do 3D animation of the nose, it links what we think with what the patient needs. And this is another way to link that when you're using fillers and toxins. This is the facial sheet I'm talking about. So I document on the face what I've injected, whether fillers or toxins. The fillers area I circulate and I document the type, the amount. I also include on the sheet the date and the patient's name. The lip is enlarged, as you can see in the lower aspect, and that is for a specific reason. In the lip, we treat subunits of the lip. So it's not a major area, it's a small area, but it has the subunits that we treat. Before and after care, this is my nurse when I first started injecting in Canada, and she was my first patient as well, as most of us have. So you remove all makeup and jewelry. I use a lot of alcohol swabs, and you'll see when we do the live demo, it's alcohol swab before, after, during. I'm very elaborate with using alcohol around to eliminate infections from my practice. I mainly use ice for numbing the area. Surgeons differ from dermatologists and general practitioners in terms of time. We like to go faster, right? So that's why I don't want to give the patient a treatment that would need 5 or 30 minutes to work. I'll just put the ice and inject, and the patient can go home. I only use topical anesthesia, eutactic mixture of local anesthetics on the lips. I feel it's still painful with the ice, so I do that. You don't want to hurt your patients or dissatisfy them from that point of view. I don't use regional anesthesia on my patients at all. Some patients do, some doctors do, that's fine as well. My setup includes alcohol swab, gauze, clean gloves. They don't have to be sterile. The patient is handling your needles and you're touching the patient's face, other areas that are not sterile. So they don't have to be sterile, you just need to use the alcohol in abundance. Always have hyaluronidase in your clinic. I'm surprised, I was talking to one of the companies yesterday, and I was surprised at the number of clinics that don't have hyaluronidase in their clinics. I think that's very dangerous, and I advise the companies to provide hyaluronidase to the clinics they deal with. It's better for the patient, it's better for the company, it's better for the doctor, it's better for everyone. So in terms of injection details, older methods, and you can see from the picture, it's an old picture. There was a linear, serial puncture, fanning, and cross-hatching technique. I've never done the cross-hatching technique. I think that's to fill a bigger space. In the recent literature and the MD codes, they've divided the serial puncturing into micro-aliquots, aliquots, small boluses, linear threading, and fanning. Targeted structures. It's important, again, to layer your products on the face. So I start with augmenting the skeleton, using heavier products down right on the bone. I think this is a difference between plastic surgeons and dermatologists. We like to go deep. We understand the structures deeper. And I believe, and I've seen it in my practice, that the deeper products stay longer with the patient. It's away from movement with skin and muscle. And you see it for doctors of you that do that, you'd see it lasting longer. So I start with augmenting the facial skeleton, then I move to the subcutaneous fat pockets on the face, and then subcutaneous injections, and last I do the lips. Again, because it might be a little bit painful, so you want to hurt the patient last. What devices do you use? For the advanced injectors in the house, continue using what you use. For the intermediate and beginners, whatever you're comfortable with. I think you need to, in my practice, I go with cannulas in dangerous areas, close to vessels, and any other place I'd go with a needle. There are millions of companies out there that do fillers. You just need to be safe and know your local authority, what they consent for you to use. So I follow the FDA, and also the Saudi FDA is also a necessity in Riyadh. So you have all these products. I divide them into, these are non-permanent fillers, so hyaluronic acid, and then longer-lasting stimulatory agents. When I first started practicing, I used some of the longer-lasting products, but later on I shifted more and more to the hyaluronic acid. And the reason I do that is the safety details of these fillers, and also, God forbid, they're not symmetrical, or you can always reverse what you've done. In the longer lasting, it's much harder to reverse. So how much fillers? Fillers differ from toxins in where you would see the results on table. So you can inject one side, and you can see the results, show the patient the results, and ask her if she would like more treatment or not, and then you can do the other side. So this will give you and the patient faster satisfaction. And it depends on patient's age, facial aging, and as I said, the patient's budget. In my practice, less is more. If the patient lives in Riyadh and I live in Riyadh, why to over-inject or over-treat? Just inject the minimum amount that would satisfy you and the patient, and ask her to come back in a few days. 3 to 4 days is more than enough to see the final effect. And when they come back, you can inject them more. So what is Vycross technology? Vycross technology is a mix of low and high molecular weight hyaluronic acid combined with a unique cross-linking process. And this results in tightly crossed link gel. What this gives you is resistant to degradation, and we see that with the better products out there, and longer duration. It also causes minimal gel swelling because of the hyaluronic acid chains. And then you're more comfortable injecting with minimal bruising on the patient. And I'm sure most of you have seen that in your practice. So my technique, I use Juvederm, and I use other products sometimes if it's not available. But what Juvederm and Allergan did, they made it much simpler for us surgeons, at least, to memorize and to practice with them. So there's 3 products: Voluma, Volift, and Volbella. Makes it easier. And then each product has a special area to inject with. So as I said, I first start with injecting the on the bone to define my my structure to start with, and give her a baseline, augmenting the facial skeleton. Malar eminence, I start on the most prominent area, and in my technique it's just one skin puncture, and then I manipulate the needle underneath the skin to inject further, medially and laterally. I do the same on the angle of mandible, so at the angle I inject I go one puncture hole, go down to the bone using sharp needle, hit the bone and inject my product. I then shift medially, just anterior to the injection site, away from the danger zone, and then go upwards as well. Same puncture hole, so you don't need to inject the patients more to decrease infection and pain. The last area where I use Voluma is on the chin. This depends on the patient's desire, whether she wants a more narrow chin or a wider chin. So if it's a narrower chin, it's the product in the midline. If it's a very receding chin, you'll need to spread that product right and left. And if she wants a more rounded chin, then I would again spread the product median and right and left using one puncture hole. The next product is Volift, and I use Volift in the nasolabial fold area. I inject only the upper half. I don't inject the lower half. I think it's unnatural, and it gives you an unnatural look, and you're wasting product. These are expensive material, and you don't want to waste them in areas that might give you side effects, might give you an over treated look. So only the upper half, and I use the fanning technique while I'm injecting this area. The second area is the marionette lines. I use a cannula and go all the way to the angle of the mouth, and I inject. This will help you treat the marionette lines and also elevating the angle of the mouth slightly. The third area where I use the Volift is the lips. So the lips, I have 3 techniques. One is on the vermilion border, and we call it contouring, to contour the lips. It's not commonly asked for. I might suggest it sometimes, but it's one of the rare sites that I inject on the lip. The second is for normal looking lip, but small, so it's beautifully shaped, but it's small, so I inject the whole lip to augment it superior and inferiorly, and I go on the line between the wet and dry mucosa. The third technique on the lip is the pursing the lip, or what we call in Arabic zemm al-shafaif. This is, again, it's a high-end trend, and in this technique you want to augment the middle of the lip and narrow the lateral of the lips, and the way to do that is to inject the white lip laterally, superiorly and inferiorly, and inject the red lip in the middle line. And I'll show you that technique when we get to the patient. The third product, Bdla, and I use that for the tree trough area and under the eyes. I inject it with a cannula and I go under the muscle. MD codes, some of you are familiar with, or most of you are familiar with this. It's they split the face into distinct anatomical units. They're trying to standardize the treatment to all patients. It's fine, again, for the beginners, but I think intermediate and advanced injectors should individualize treatment according to their patients. There are a series of predefined injection sites with subunits within each anatomical unit. They demonstrate how to rebuild the units in an architectural model. So I differ from their injections with the multiple sites and also standardizing versus customizing. Complications, if you haven't seen complications, you haven't done enough, or your complications went somewhere else. So you need to know your complications, you need to know how to treat them. They will happen at some point. You just need to be aware of that. You need to have consented the patient that this might happen, and you need to know how to deal with it. So one of the most common side effects, I would say, maybe not complication, is overfilling the area. So the first technique I would do to that is massaging the product. And with simple massaging, this treats 90 to 95% of patients who I inadvertently overfilled. Secondly, you can use hyaluronidase. There are 2 techniques to use hyaluronidase. You can use a higher amount to liquefy the product completely, and that's good where you have intravascular injections or, God forbid, blindness. But when you have overfilled, you can use lesser amounts to just dilute the product and make it less. Last of which is extraction. I've never needed to do that for overfilling. Next is infection. Again, this might happen. It happened initially in my first few years of practice, and I think I wasn't very meticulous with my alcohol usage and cleanliness. And later on, I started understanding this more, and like I said, using alcohol a lot more, and it almost eliminated from my practice. But it might happen, and I'll tell you about a patient who came to me a week ago. So 4 months ago, I've injected her nasolabial folds. She was happy with the treatment, everything was fine. 2-3 months later, she came and she said, "Doctor, I feel the product. I feel it's not gone yet." I said, "That's excellent. You want the product to stay longer, and it's a safe product. If anything happens, we can melt it." A month after, she contacts the clinic and she asks to see me because of pain and swelling in that area. So I bring her in, I examine her. Yes, I feel a lump now, and it's tender in comparison to the other side. So what I did, first I asked her a few questions. One of them, did you have any dental procedures recently? Just before the pain, a day before the pain, she had dental cleaning. And what happened is that a bug must have transmitted to the area, and still it's in the subclinical phase, And that's why it's important to be in touch with your patients all the time. I've injected hyaluronidase, a bigger amount. I want to liquefy the product completely. It's done its job for that 3-4 months. And I also put her on oral antibiotics. It took 3 days for her symptoms to completely go away, and then she came back and I felt no lump, no tenderness. So infections might happen. First line of treatment is using oral antibiotics. I don't think you need to go for IV antibiotics. If it's that much, you might go for extraction or melting the product. Inadvertent vessel injections, you can only treat that with hyaluronidase and patience. These patients take a long time to heal if God forbid it happens. So you need to be patient. You need to be around your patient. I remember a talk when I was a resident actually about a doctor who had a rhinoplasty patient, and they thinned the tip a lot, and she had necrosis of the tip of the nose. And what the doctor did, he said, I've answered her phone calls all the time. She asked to see me at the middle of the night. She asked to see me at the gas station. I went, and I've been with her throughout. You need to be patient with these patients, and hopefully they will heal with less scarring. And there are many modalities to treat these patients. He ended up with doing a forehead flap for the plastic surgeons in the house to cover that, and she had minimal scarring around the face. You don't want to have that in your practice, but if it happens, you need to be patient. So now we'll shift to the live demonstration. I'll show you my technique. I'll try to do the best practice throughout. I'm not sure we'll call for a break. Just give me 2 minutes to set it up, and we'll be with you shortly. Thank you. I think we can open the house for questions. I can answer while I'm preparing the patients for them.
Thank you very much, Dr. Amir. Very informative. I'm sure you have a house full of people who inject. So
yes.
many questions. Dr. Amir will receive questions while he's preparing for the live demo. So feel free to ask. We have a mic on the stand. Any questions?
Don't be shy. Just ask. If I don't know, I'll say I don't know. There are much more senior تورطنا. I'm dead.
Thank you very much, Amir. Very thorough presentation.
Thank you.
I wonder if you can tell us how to inject on top of a filler of an unknown origin or a filler of a different kind. Can you mix two types of fillers?
Very important question actually. If you don't know the product, I would assume it's a permanent product, because the patient usually know their products, or you can ask who injected your fillers, and most of us know in their town or their city who injects permanent fillers and who doesn't, right? So if you don't know and the patient doesn't know, I would not inject on top of that, because I would assume that's a permanent filler. I don't treat permanent fillers, I don't remove them, and I don't inject over them. I tell the patient, that's it, you had your one chance and you've ruined it. In terms of knowing the product, so any product that is dissolvable, whether hyaluronidase or calcium products, you can safely inject hyaluronidase on top of them. As you know, hyaluronidase is a natural product, so it's fine to inject them on top of other products. There are no contraindication from different companies to use different products. So I don't have any problems injecting over non-permanent products. I tell the patient that there's a possibility of infection. I'm not sure if it increases or not in such cases, but that's always there, right? And if you have the product initially, and if you inject it again, you might inoculate that previous product that is stable and fine with that small bug and cause infection. How are we on time? That's perfect. Thank you.
We need to start the injection.
Sure. Aywa.
Since we want to inject with the hyaluronidase, with the hyaluronic filler,
Yes.
hyaluronic acid filler, what's the contraindication of injecting for example, the lead of a pregnant lady?
With hyaluronic acid? There are no studies that show on humans the safety of these products. So for me, I don't inject them at all.
This is a natural product, right?
Yes, I know. But just because we don't have enough studies, you know, it's better safe than sorry. I don't want to be that first study in my practice. You're welcome. Gloves? I have my gloves, yes.
Excuse me. Now we are experiencing more of granuloma of hyaluronic acid, and we have seen in our clinic, even from Jupiter, since you are injecting the substance.
Yes.
Is there any interpretation that people they are
No,
not
don't give me one of each.
they are not
Give me one
reporting
of
this
each.
in the reporting, or technique, or manufactured errors, or why we are seeing more and more, and we are hearing more granuloma from the hyaluronic acid?
I think the main reason for having granulomas is not being meticulous while injecting, and injecting more superficial, the product more superficially, and in boluses superficially. So I'm against injecting superficially with boluses. I go deeper with boluses. So that's number one. Number two, the products, I'm not sure about different manufacturers, if they have changed their linking and product manufacturing to cause these granulomas. But if that's the case, we would see it in our practice as well. But I'm sure in your practice, these granulomas are not as much as the more junior injectors or outside of your clinic. And the good thing about these products is that if that happens, you can treat it safely. Sweaty a little bit. كيف حالك? So first we'll start with the consultation. I'd ask the patient what are her main concerns. We had this consultation behind the screen, but in terms of facial features, what would you like to improve on?
Of course, the cheeks.
أيوة, أقدم عشان الميكروفون.
Cheeks. The first thing.
Yes.
And also the chin here.
So as she's talking and telling me all these areas, I'm thinking, does she really need that? And I do agree with her on the cheeks and the chin. She has a protruding chin. As you can see here, she doesn't have a mental crease, so she'd benefit from the product there. Also the cheeks. Any other areas of concern?
Here, this area, I think.
Nasolabial folds,
Yeah.
I agree. It's tricky with our model today, Hiba, to treat the nasolabial folds because of the protrusion of the upper and lower lip. So there, she has a maxillary protrusion, and that might be a little bit tricky. And it's difficult to see it on the camera and also on the photos that I've seen for the patient preoperatively. So you need to be careful and maybe minimize the product in that area just to camouflage the upper half of the nasolabial fold. Also, the most important point, I will mention it because that's the first thing I've seen when I've seen the photos is the lower eyelids.
Yes.
So the hollowness under the eyelids. The best treatment, of course, is surgical, but today we're talking about injections, and we can camouflage with fillers in the area. And again, it's a safe product, and we use it just underneath the muscle. Okay? Other areas that we're going to inject and discuss are the angle of the mandible. This is, again, a common trend, and we've discussed the trends with the patient. She would like a more structured face, وجه منحوت أكثر. You don't like the chubby faces like my patient from the north, right? Okay. So, again, I use clean gloves. They're not sterile. The patient has prepped, the nurse has prepped the patient with alcohol swab, and she's been treated with eutactic mixture of local anesthesia just for the sake of time. As I mentioned, I start injecting the bone first. I'll shift it a little bit so you can see with me. I sterilize the area that I'm working on. So here, that's the cheek injection, volume. I use sharp needles in this area. I've worn the lab coat and the scrub suit today to demonstrate that as well. I removed that before the treatment. I just forgot. Very anxious. You need to have, you don't want to transmit infections with your gloves. I've sterilized the area already. I have alcohol swab all around me. She's ready with alcohol swab as well. That area hasn't been touched again. And so I point out the area, maximum protrusion, and I go in with one puncture hole all the way down to the bone, okay? And I inject my bolus on the bone. I aspirate before injecting, and then I inject directly on the bone. Do you feel any pain?
No.
Okay, perfect. So I inject 0.2 to 0.3 in that area. I do not come out of the skin. I just pull out a little bit. I'm not sure if you see that on the screen. I tilt my needle medially, again, hit the bone, and inject the other bolus. So it's similar to the MD codes, but I just don't like the multiple injection sites. This not only treats the cheek, it also treats the lower bags laterally, not medially. And then the last part, again, I don't come out of the needle, and I go medially. So you're drawing that cheekbone, okay? And you can see here, I inject on the bone. I'm not sure if this is clear. Another 0.2 to 0.3 on the bone. So that's almost a full needle. And I think you need, I use alcohol swab again. Some of you would use a gauze here to clean the blood. I use alcohol swab. I might massage the product just a little bit to spread it.
Dr. Amir,
Yes.
what are you doing
Was she
on
doing it?
aspiration? Do you need to aspirate?
Aspirate, yes. I mentioned that. You have to aspirate before injecting, no matter where you're injecting. It's not in the danger areas only. Always, best practice is to aspirate. So now if you tilt your face forward, and you can see that already, she has a more prominent cheek on that side in comparison to the right side. So I'll inject this half first, all over, and then we'll inject the other half, if we have time. The second area of concern is the angle of mandible. Again, that has been anesthetized with EMLA. Sterilize the area. Don't sterilize and retouch and repoint. Understand your anatomical landmark beforehand. Here I'd like to identify, give me a red marking pen. I'd like to identify the vessels. So in the cheek, we do not have any danger area around the cheek. But when we're moving down to the angle of the mandible, and later to the nasolabial folds, you need to identify those vessels. So it's midway in between the chin and the angle of the mandible. Somewhere here, if you feel with your finger, you might feel that pulsation. Okay, there it is. So that's the facial artery. It crosses the angle of the mandible, artery and vein, and goes all the way up here, gives you the superior labial artery, inferior labial artery, and then continues, usually lateral to the nasolabial fold. And goes all the way lateral to the nose. We see that when we're doing our rhinoplasties, and then it connects with vessels in the glabellar area and in the eye. So you need to be aware of the course of this. I'm injecting on the chin, I'm injecting on the angle of the mandible, I'm not injecting in this area. Usually you don't need to inject this area because you have the jowling in your patients, and the jowling is in this area, so you don't want to inject in the jowls. You might need to liposuction the jowls instead. So inject pre-jowls and post-jowls. Again, voluma. I've identified, I've cleaned, I think you've seen on the screen how many times I've cleaned. I think it's turning to a psychological problem to me. So angle of the mandible, I've not touched the areas I've sterilized, identify the angle, and go directly all the way to the bone. The patient might feel this injection in her teeth. Okay? I tell her that's fine. If you tell her, she'd feel much better that you're not doing anything wrong. And I inject the amount needed. So we've discussed this preoperatively. I need almost a bolus in this area, a full cc. So I go 0.5 at the angle. There you go. And then mobilize your needle. So same puncture hole, I did not come out. And then go more anterior on the bone. She's felt it. You can see her grimacing a little bit. Aspirate so you're not on a vessel. Inject 2.5 cc's anteriorly. And then again, manipulate your needle. Stay in the skin. This decreases infection and pain. And I'm go superiorly, again, on the bone. All my needles in this area are on the bone. Aspirate and then inject. Perpendicular in the first site, and the other sites are a little bit angulated, just because I don't want to puncture her again. If it's always perpendicular, you're puncturing the skin more times. Okay? An important point to talk about is that these needles, they're very fine needles, right? And if you hit the bone with them, you might blunt the needle. So if you're using the same needle on both sides, what I would do, I might ask the nurse to change the needle. So this is done now. We don't need to change anything. But if you're going with half an injection on each side, I would change the needle if you're hitting the bone. Because if you go through the skin again with that same needle, the patient will feel pain. Okay? So let's raise your face ahead. Here, raise your head up a little bit. You can see the elevation of the jaw. If she turns, you can see beautiful demarcation of the angle of the mandible. So what I'm trying to do when I'm injecting, you can see less definition on this side. I think because of my practice as a plastic surgeon, I do facial implants. I put permanent facial implants, whether silicone or porous polyethylene. So what I'm trying to do with these injections is to simulate that implant. And hence, I try to get the same results. And it's the same thinking process for my fillers and my implants. If the patient needs a small implant, it's usually a half to 1 cc. If it's a medium-sized implant, we have small, medium, and large. Very simple again, 3 products. The small, half to 1 cc. The medium is 2 cc's, and the large is 3 cc's. Okay? So we've demonstrated the cheek, we've demonstrated the angular mandible, and now we go to the chin. As I mentioned, she has a retruded chin. I want to simulate a chin implant for this patient, alcohol and voluma. Some people go from underneath the chin, some people go directly, some people have multiple holes. Again, in my practice, I go 1 hole on the face. I do it in the midline. The midline is usually avascular, and the amount of fillers that I would need to inject here to start seeing the results is minimum of 2 cc's because of retrusion. So I'll tilt the patient a little bit so you can see the needle. Okay, so I pinch the area. I always pinch, whether Botox or fillers. I think it makes it more comfortable to the patient where you're not dragging the skin and pushing the skin. I sometimes see videos or other doctors injecting with one hand and trying to do something else with the other hand, whether pressure on the patient or using these vibrators. Yes, nerve distractors. I can't see me doing that in my practice because I always, as you've seen here, I always hold the area, and that will not cause dragging and will cause less pain to your patients. Yes. Much less painful. At all. Okay, so here on the chin, midline, inject all the way down to the bone. I hit the bone, I've hit the bone, I've blunt my needle, and now I'm injecting, aspirate, and then inject. And it's usually, you felt it in your teeth, I think, right? Mm-hmm. Yeah, I see that flinching. And I inject that whole cc. I've discussed with Hiba prior to the injection, her desire on the chin. Does she want a more rounded chin, or she would like it more pointy? And she said more pointy. So I put 3/4 of the needle in the midline, and then the last quarter I would spread. Again, It's difficult with the needle in the face. Okay, you see that? So I pull it out, not out of the skin. I angulate it medially and laterally. She might feel a little bit of pain in this area because of the mentalis muscle. In the midline, the mentalis has a aberration of it, and it won't cause any pain. But laterally, she might feel a little bit of pain on the muscle. Again, there are no vessels or nerve in this area, so you're usually safe. It's just the muscle that she might feel and flinch a little bit. Okay, so that's a full CC, and we'll see the patient together. I will need another injection. You can see, you see some contouring. Yes, some contouring. She was much more receding, and I said that before treating, she would need another injection, 2 to 3 minimum. So let's have another needle. I'll do that faster. How are we doing with time?
Very good.
Good? Okay. Good.
I think at this point it's always a good time to give your patient
The mirror. Yes.
and tell them, look at this side, the one I've done, and look at the other side. Because once you're done with the other side, they can't see the difference.
Perfect.
This is a good time to make them appreciate your work.
Yeah. Okay, so again, I've sterilized this area. أعطيني alcohol swab again. See? Obsessive compulsive. Sterilize the area. Same puncture hole. Try to get the same puncture hole all the way down to the bone. Same technique. Most of the bolus on the needle. Sorry, let's turn a little bit. Okay. Whole bolus in the midline. And because it's deep on the bone, they would not develop lumps or granulomas in the area. And the product will spread just below the periosteum. Whole CC. Are very happy. Yeah.
Especially women who wear hijab or cover the head. The chin area is an area that we always look for to improve. It's a very simple one.
Now you start seeing that coming out nicely. Okay? So I've tried to take one model and to do all the treatments on her. She does not need any filling in the lips. She might need surgery to reduce parts of the lips to do what we call بالشفاة or pursing. But that's it. So these are the 3 sites. Give me gauze, please. It's important to know that when you use alcohol swab to eliminate your infection, every time you swipe, bleeding will come more. So what I can do, I put an alcohol swab or use alcohol swab on my gauze and apply pressure. You can ask the patient or the nurse to apply pressure in the area. Okay, so voluma, or heavier products. The heaviest product on the cheek, angle of mandible, and chin. I'm not sure if you see this on the video. You can see some grooviness just above the filler. That's fine. I said you can either try massaging the area, but don't panic. What you can do is ask the patient to come back in 3 days. This might disappear completely. They would look a lot better. The swelling has taken effect. The product has melted and not melted, but distributed itself in a better way. So I wouldn't panic. I wouldn't inject her more, especially that we've done the budgeting beforehand, right?
What's your views on massaging? A lot of doctors massage a lot. I personally think you should not. You should
Yes.
just press and just make a little bit of pressure if you want, but don't over-massage what you've just injected.
I agree with you totally. This is for the doctors, not the patients. So I ask patients not to massage. They don't know what they're doing. So no massaging whatsoever. It's the doctor who does the massage. Initially, if you see that the product has accumulated a little bit more in one area, you massage it. Otherwise, I wouldn't touch it if it's good.
Patients will ask you what
Of course.
they're breathing. Shall I
Massage it,
Shall
shall
I
not.
put cold compressors?
Yes.
Shall I put hot compressors? So I think
Nothing.
you should not do that.
Not do nothing to the face. Okay. Just for the sake of time, I'll continue injecting this side with the other areas. So, we'll have Vol lift, please. The other area I'll inject. So these are the sequence I do. First is the structure, bone. Second, subcutaneous tissue. third, submuscular tissue on the eyes or the lips. Okay, so in the nasolabial area, no, just a needle, a sharp needle. We've mentioned the vessel. So this is your nasolabial fold. You should go always medial to that area. I only treat the upper half of the nasolabial fold area. I do not treat the lower half. She does not need treatment actually in the lower half. She has fullness in the lower half that I might improve on when I inject the upper half. Okay, so that's the site of the vessel. Again, you can inject in the vessel, but just be aware of that. Tell the patient it's in your consent, and be much more superficial. Okay. So here again, I use both hands, and here is crucial. So I've delineated my nasolabial fold. If I haven't done so with a marking pen pre-op, I would push slightly on the patient's face, and you can see that fold developing, right? So when you see that, you just want to go medial to it. If you go lateral, you'll hit the vessel, you'll augment her nasolabial folds. You're actually causing the patient more damage than good. Okay, I pull on the skin, one puncture hole, and then subcutaneous. I start with the angle, I aspirate, it's crucial to aspirate in this area, and then I inject as I'm pulling out. Usually in the nasolabial fold, I do a half cc. Every time I push in, I aspirate, and then I inject. Usually it's a half cc fanning technique. It's a little bit painful to the patient when you go, when you touch the muscles in the area. In our model today, we don't want to overdo her because of the fullness of her lips, both white and red. You can continue doing your fanning technique to augment the area. You might come out and assess, and then a few seconds later, you inject again. Your product, if it has xylocaine in it, she would not feel pain. And that's it. So, no massaging. I tell my patient that they might feel a lump in this area. I think it's natural to have a lump in this area just because of the small size of the area that you've injected. If you compare right to left, that line, marking pen, completely gone. Completely gone. And if you have injected this patient, okay, if you have injected this patient down here, you would cause a major disaster to this patient, and you would need to melt it. So this has not only treated her nasolabial fold, but also equalized the fullness that she has. We're camouflaging. A lot of times when you're using fillers, you're camouflaging, okay? So that's the nasolabial fold injection. What the patient, God forbid, might have, as I mentioned, they'll have pain. If you inadvertently hit the vessel, they'll have pain. You might want to tell them about that preoperatively. Okay, so the last area we'll inject on this side is the tear trough area. Marking pen. In this area, I always use cannula. I'll delineate for you, I'll delineate for you the area that you want to treat. It's this depression. Okay? So this depression is where the muscle is attached, or there are attachments between the muscle and the bone. And what you want to do is to try to fill up this area to get rid of that depression. What we do in the operating room is we open a subciliary incision on the skin, we elevate the skin and the muscle, and we dissect through that layer, through that depressed area. And we transmit, or I transmit the fat from the pocket. I open the pocket, I transmit the fat to the area to camouflage it again. But that's a permanent treatment. We can use fat as well in this area, and we can use fillers. So fillers and fat, I believe they're camouflaging the area. You can buy time with the patient until she needs that operation at some point of time.
So you're going to inject under the muscle?
I'm going to inject under the muscle. I go with a cannula, depending. So we have a 5 centimeters cannula, I usually go lateral. So this is my first injection site. If she has the depression only medially, I might go through the same site, but in her situation, she has more lateral depression here, so I want to go more lateral with my injection. I'm using 25 today. If you go narrower than 25, it doesn't differ more from the needle, and you can inadvertently inject the vessel. Half ml on one side. I never exceeded half an ml. Okay? Can we have a closer view? You can see that depression over there. It's very clear, marking pen. Much more improved. I wouldn't inject more at this point of time. I'll tell her, don't worry about it, it'll improve. If it doesn't, come back in a week and I'll inject more. But at this point of time, I'll just stop. She will develop swelling. I tell all my patients with fillers, they develop swelling for 2 days and then they improve. Okay, so how are we doing with time? Should I inject the other half or do the lips?
You want to do the lips?
I can do the lips, I can do the other half بعدين. اوكي بيرفكت. لا ما حسيبك حسوي لك بعد الانجكشن. ايوه شوف المرايه شوف if you need any more products عندنا products مليان. خلاص حنوقف. لا تفضل ازيك. I'm left-handed. I usually inject the lips from the left side. The face, if I injected the first model on the other side, I usually go to the other side. It's very hard to inject from one side all the products. You can't assess the anatomical area very well. Alcohol swab again.
When you're
So
injecting, you're usually going around your patient because you're looking from every angle.
every angle, for sure.
Sometimes even from the back, and you look at the cheeks. It's very important to assess the face while you're injecting,
Yes.
not just at the beginning.
رجعي راسك شوي ورا. مخدر ما عجبك. Okay. So even after the nurses sterilize the mouth or the lips, I usually do it myself because what she's done, she's perfect, okay, and maybe the technique that her surgeon or dermatologist does is a bit different than mine. So what she did is did this, right? So that sterilized the outside of the mouth. It did not sterilize where I will inject in my technique, okay? So I asked her to part her lips a bit, and I also sterilize that mucosal wet and dry section, okay? In the lips, I'm extra cautious again from infection from the intraoral. It's a dirty area. I know that because of my surgeries on the angle of mandible, I go through the mouth, so I'm very, very meticulous with the mouth. Sometimes after each injection on the lip, you need 3 or 5 injections on the lip to spread your product. I would sterilize after each injection. So off camera, we had a discussion about Muna's lips, and as I mentioned, I have 3 techniques. Can I have the marking pen, please? I make it simple for me. You know, maybe dermatologists are more clever than us, plastic surgeons, but for plastic surgery, we try to simplify things for us and for our patients. And it's good for teaching, and it's good for, you know, I think in all aspects. So one area is the contouring of the lip. I find it less common in the Middle East to need contouring. Most of them have good vermilion border, very distinct. They might want to control it with some makeup. So I rarely inject the vermilion border, okay? And the way to do that is, the way I do it, is linear punctures within that vermilion border. Upper and lower lip. I think it's painful. You might want to wait a little bit longer on your EMLA or topical anesthesia, or you want to inject local in the nerves. So that's one technique. The other technique, which we've agreed on today, is that she has beautiful lips to start with. And if she does have that, and she's not interested in changing the shape of the lip, so I would just augment the whole lip. You have to keep in mind the balance between the upper and lower lip. The lower lip has to be slightly bigger than the upper lip. Her main concern was that the upper lip, when she smiles, almost disappears. So we'll try to treat that with the fillers today. The third technique is what we call in Arabic zemm shafayif. I won't be demonstrating that. That's my top secret, so I won't show you that. Actually, it's not. But you augment the middle of the lip in this area and the lower lip where it's usually naturally augmented. You don't put any products on the lip laterally. If you need to, you might want to inject above and below the red lip, so in the white lip, to camouflage that and make it more narrower on the sides. So imagine she'll have a fuller lip. You'll have a fuller lip in the middle, okay, and narrower on the side. So that's the بالشفاة. But what we'll do today, for the sake of time and patient satisfaction, is we'll just augment the lip in total. Are they numb? مخدرين? Okay. Here, I've seen many doctors injecting and using that distractor. How can you control the lip while using the distractor on the lip? I have no clue. I have no clue. You have a nurse, she can use the distractor. You use EMLA, you use all the other modalities to... Okay, sorry. Is it good? Okay? راح احترق? Okay. I start with the upper lip. Is it okay? Are we on? Hello? Too much for a live demo. Hello? Perfect. Okay. So upper lip, sterile. What I do, I pull the lip, I identify that line that I want to inject, and I start injecting laterally, medially. Stay in that layer. Don't go deep. The vessel is behind you. If you want to aspirate, go ahead for safety measures. And I inject while I'm aspirating, and do move the same pressure that you're injecting, you're moving and pulling that syringe out. So that prevents boluses and accumulation of the product in one area. Okay, alcohol swab. That's what I said about alcohol swab. It's always next to me. I'm always wiping the lip. Is it too painful? It's okay? No. Oh, perfect. Okay, so you can see that augmentation already starting to appear. Minimal product. I've just used 0.1. Okay, again, I go at the end of my needle where I've injected, go all the way medial. They start having a little bit of sensation more medially, and I'm injecting as I'm pulling out. Okay. Again, another 1 cc. I just press on the product a little bit just to make sure there are no accumulation of product on the lips. Okay. And then again, so this is, I think, the simplest, most satisfying technique for patients and doctors. I'm injecting as I'm pulling the needle out. Again, no lumps, just a linear thread. You can feel that thread when you're more lateral. See, pulling this lip and controlling the lip makes it less painful. Aspirate and then inject as you go. Again, less is more in my practice, so I don't inject them a lot. I rarely achieve one needle in one session. Okay, sorry. Last injection site on the upper lip. Again, as I'm going out. So that's for the upper lip. So I've used, if you see this, 1, 2, almost 3. Almost 3 on the upper lip. I'll do the same on the lower lip. The lower lip are less painful. Okay. Aspirate and then inject as you are coming out. Very simple technique. I know there are many techniques out there for the lip, but this I think is good for augmenting the lip in total. So I'm augmenting every structure as much as it needs. I'm not putting products in a special area or subunit more than other areas, because I've agreed with the patient that she has beautiful lips to start with, so just augment everything.
Do you use cannulas for the lips?
No. Perfect. So no lumps. Okay, excellent. They might have a little bit of a swelling in the site that I've injected initially, and then as you go, you'd see it less. I'd say don't worry about it. The rest will swell in a few minutes. She looks at the mirror. Usually, I don't do any further treatment after this. I save this for her. It's okay to save the product in a fridge under the patient's name and utilize it again for the patient's sake. There are studies that showed no infections doing that. Okay?
How long do you save it for?
Usually a month.
1 month.
1 month for the patients only. If it didn't expire as well. There's an expiry date as well. Sorry? GCIA 8 days. Okay. So follow that if there are guidelines from your authority. But I've read a study that kept the product for a year. It's still within expiry date, and no infections happened. This practice somewhere. I think it's either American or Canadian, and they kept it for 1 year with no infections. It's always better to be safe with these products. I think that's it for our demonstration today. If you have any questions about the technique or specifics.
We'll open the floor for questions. Please ask.
Thank you. هنكمل بعد هذا. أعطينا ولا بلاش الكورت بعدين. أيوه.
May I have a suggestion actually about the first case?
Yes.
On the left side of the case, you did the automatic augmentation. Or
Yes.
peak augmentation. And you are very careful to use one puncture.
Yes.
To go vertical and then medial then lateral.
Yes.
But actually, to my opinion, we have to suggest to ask the patient first, the comparison, her acceptance to the job. Second, the suggestion is that because I noticed being very careful not to puncture more, the length of the needle will be localizing the filler to certain area,
Okay.
which actually augment the zygomatic body only. But if we want it more natural,
Part of the arch.
we go to the arch.
Yes.
The posterior zygomatic arch. So I prefer go vertically on the zygomatic body, on the most tip of the zygomatic body,
Yes.
and have another function on the
More lateral.
on the lateral ramus of the zygomatic arch. This will become more natural, and the patient will feel a localized cheek lump,
Swelling.
which usually patients reject, especially if they have already bulky cheek.
Bulky cheeks. Okay.
So I actually drawing the natural bone construction.
Yeah. I agree with you totally. As I mentioned, this is my technique. And if you really need to go more lateral, what you can use is the mobility of the skin. So keep that needle, mobilize the skin, and you can go even further in the area. Or if you want a longer needle, you can use a longer needle to reach that area. And if you have to, use another puncture hole by all means. But that's what I do in my practice. I usually do one puncture. If I really, really need to, I would do that. Or as I mentioned, I can do it in a second stage when she comes later on and augment that arch on itself, by itself. Thank you.
Another question on this one?
Ajlis? You're not hungry?
I'm always a patient coming to my pharmacy complaining of herbs after left filler.
Yes.
So would you have any explanation of that and how the needle it would be safe to re-inject although the patient having herbs after the injection?
Herpes. So
How to protect that also?
Okay.
how to protect?
How to prevent getting herpes? Well, I think we should talk about the people who have the liability for cold sores and herpes infections.
So patients.
And fillers.
So patients that have that tendency prior to injections might have it after your injection. So you need to be aware of that in your history taking. And if they do, you would need to treat them post-injection. I'm not aware of any prophylactic treatment. Are you aware of any prophylactic treatment while you're injecting or before?
Usually with patients, if they have a history of herpes or recurrent herpes,
Okay.
2-3 days before the injection.
Yeah.
Now, fillers themselves do not cause herpes.
Of course.
I think we have
It's
to
just-
clarify this. Fillers don't give you herpes, but patients who are known to have recurrent herpes infections, and you should know that from taking the history from the patient first, then you should be careful. Maybe it's better to give them like a 2 or 3 days antiviral beforehand if they have very active infection. Now, mind you, this is very common, and not everyone actually will need to be on antiviral.
Yes.
From my experience, a lot of people maybe get it once or twice in a year.
Yeah.
That's not a big deal. But if someone comes to you and she tells you, I get it very often, sometimes I feel safer to tell her, take an antiviral 2 or 3 days just ahead of giving the injection.
Yeah.
And that's it. And usually you can control that.
And do you, I might worry about superimposed infection with these patients, so putting them on oral antibiotics after you inject, I think is also a safe measure. Just to worry about superimposed infection.
Any other questions?
Hi, good afternoon.
Good afternoon.
My name is Francisco Mello. I'm also a plastic surgeon. Well, first of all, to congratulate you for keeping us entertained for 1.5 hours.
Thank you very much.
Big task. And I cannot left a note to touch the subject of complications, and you mentioned something about granulomas. And there was something we discussed about it. The thing is, granulomas are an extremely rare thing to happen. The majority of what you face is nodules.
Yes.
And nodules, and we are physicians, and sometimes when it comes into cosmetics, we forget a little bit. We have to proper diagnose and distinguish one from the other, because they are totally different identities. Nodules, as you show us with your brilliant technique, are preventable.
Yeah.
It's a matter of technique.
I agree.
It's about injecting too much in the wrong place. Granulomas is a non-specific inflammatory reaction. You don't know exactly why it happens.
Yeah.
There are several theories. Biofilm can be one of them. It's still not proven. But the truth is, it's related to good diagnosis, good technique, and using the basic things like sepsis and
sepsis.
and follow up the patient.
Yes.
So thank you for
No problem.
getting it clear for us. Thank you.
I think to cover fillers and toxins, we usually do 2 to 3 days of lecturing. It's very difficult to squeeze them in half an hour. I think the complications by itself would take half an hour to an hour to talk about, with all the fine details. But thank you very much for your comment.
Thank you. I think nowadays we don't see granulomas, but we see more of
Nodules.
necrosis and nodules.
Yes.
So inexperienced injectors, more of like vascular problems, and I think it's very important to be able to recognize the complication.
100%.
Because the complication can happen in any hand.
Yes.
But if you are injecting, you should know how to handle these complications.
Of course.
You can't tell the patient, oh, it's just infection, or it's, oh, it's your skin type. And that's what we hear sometimes.
And we've seen misdiagnosis with patients with necrosis diagnosed as infection and given all the antibiotics in the world.
Allergy.
Yeah.
Maybe we should point out, it's not that common to have allergy actually with fillers. So this is very important. If you inject and you cause a problem, you have to be able to recognize it and deal with it. And this is what is the difference between a good injector and a bad injector. And I think I always tell patients this. This could happen, but we know how to deal with it, and this is very important. I think the message you gave us, Dr. Amir, today is that we need to inject
Safe.
deeper, and we have to have the right technique,
Yes.
and we have to know the anatomy of the area we're
100%.
injecting. Keep everything clean, aseptic, and that will limit your problems and complications.
Yes.
And always inject less.
And 100%. And if you have any doubt, you could not diagnose it. There are always senior doctors to you. So when I had that complication with the necrosis, slight necrosis on the nose, I've showed the photos to Dr. Jamal Jum'a, I work with them in the clinic, and Dr. Fuad Hashim, and they agreed with the diagnosis. I asked the patient to fly in from Dammam, and she came in and we treated her, and then I stayed with her 2 weeks, you know, on continuous follow-up, documenting the necrosis, what happened, and that started shrinking to a small scar that the patient is accepting. So just be careful and follow up the patient.
And how to
100%.
handle your patient after that. Any more questions before we break for lunch and prayer? Last question? One more, just one more.
That was an excellent presentation.
Thank you. Thank you.
And most of the cases, when I do fillers with acne scars and scars of varicella, you know, there is a phenomenon called downloading where when we do fillers, the rim gets elevated and the center gets more depressed. Have you faced this situation and how do you tackle this situation?
Excellent question. I'm not the person to talk about this. I don't treat acne with fillers myself. I leave it to the expert dermatologists. So we have a dermatologist in our clinic, or our neighbors at Derma, we transfer the patients to them for that specific treatment. So I've never treated them. I'm not familiar with this. If Dr. Nihal or Dr. Laisa would like to answer.
Yeah, I think I agree with you 100%. I think filler should not be done unless it is a rolling scar and you subside it before. If you do subcision and you inject, you might have. Majority of my patients are not happy with the filler of the scar. So I'm not doing any more filler of the scar. I agree. I think you have to be very careful from the donor. So just rolling scar, and you have to subside it well, subcision, sorry, and then you can do the filler. But I'm avoiding those patients because satisfaction is usually not as good as what we expect theoretically.
Yes.
Even I have tried subcision techniques before doing the fillers and it has worked out well.
Thank you very much.
So even we refer them to the dermatologists, and the dermatologists have no treatment. But the patients need to know this. They need to know from the experts in the field that there is no treatment for such areas based on the diagnosis. I think that's crucial as well.
For scarring, you have to do so many different modalities.
Yeah.
Frequency, subcision. I think fillers comes low on the list in my personal opinion. Last comment.
Actually, I have an experience about non-cross-linked hyaluronic acid using the post-acne scars. If you inject it frequently or in sessions, it improves a lot.
Okay.
By deep injector, like 3 milliliter tips.
Okay.
But not lateral, non-cross-linked.
I refer all these patients to the dermatologists. I don't deal with them. I guess that's it.
Thank you very much, Dr.
Thank
Amir.
you.
This was very interesting. I'm sure everyone found it very useful, interesting.
Alhamdulillah.
And
Thank you very much.
Wish you all safe injecting.
Yeah.
Thank you.
Thank you for inviting me. نكمل. هكمل الشغل.